Now, Lord Clarke, we'll ask you to take the oath. Mary will take you through the oath.
I gather you don't want me to stand for the oath.
You can stand or sit as you please.
Most people sit, that's fine.
These people stay sitting, right.
Please state your full name.
My full name is Kenneth Harry Clarke.
Take the book in your raised hand and repeat after me. I swear by Almighty God.
I swear by Almighty God.
That the evidence I shall give.
That the evidence that I shall give.
Shall be the truth.
Shall be the truth.
The whole truth.
The whole truth.
And nothing but the truth.
And nothing but the truth.
Lord Clarke, I'm going to start by asking you a handful of questions about your parliamentary career. You became, I think, an MP in 1970 and remained an MP until November 2019.
Correct.
Now, you've held a number of government positions, but the two in which the inquiry is interested are your tenure in the Department of Health. You were Minister of Health in the Department of Health and Social Services, as it was then called, from the 5th of March...
Health and Social Security.
Social Security. 5th of March 1982 to the 1st of September 1985.
Yes, if you look that up.
And then you were Secretary of State for Health in what was then became very rapidly the Department of Health, separate from Social Security.
Well, it was. I was sent there when it became, when the two halves, quite distinct halves, of the old DHSS were separated. They'd really always had operated as two separate departments. So I was the first Secretary of State for Health at the Department of Health.
And that was from the 25th of July 1988 to the 1st of November 1990.
If you tell me so, sounds right.
And both those posts were in the government of Margaret Thatcher.
Yes.
Now, you've held a number of other ministerial positions. You've listed those in your statement, and I'm not going to go through those. You became a peer in September 2020.
Yes.
But before I ask you about any of the substantive issues, can I ask you this? Have you signed the Official Secrets Act? And if so, does that inhibit or restrict the answers you give?
I think I have signed the Official Secret Act many years ago in one of my government posts. Yes, I probably have. I obey the Official Secrets Act anyway.
But does that restrict or inhibit or prevent you from answering any of the inquiry's questions?
No, not on blood products. No.
Now, I'm going to concentrate today on the period of time that you spent as Minister for Health, 1982 to 1985. And just so that we can understand who the ministers were in the whole department, as you've indicated, the department at that time was responsible for both health and social security. And the Secretary of State, the top of the ministerial hierarchy, was Norman Fowler, now Lord Fowler.
Yeah, and he was the only one who bridged the two. It was a very odd combination. I think they were just regarded as part of the welfare state. But actually the health ministers had nothing whatever to do with pensions, benefits, and all the rest of it. And the social security ministers had nothing whatever to do with the National Health Service, community care, and all the rest of it. Norman presided over both and was the cabinet minister and the head of the whole thing. But they had two really quite separate chains and quite separate teams of officials working below him.
And then in terms of the health side, you were, as it were, the next one down in the ministerial hierarchy.
There's three ranks of minister. Secretary of State, usually cabinet level, top of the head man with overall responsibility for everything. Then Minister of State, which is a kind of, Sergeant Major or something. You're the next rank up, but you have a kind of wide range, but you have specific responsibilities. And then the Parliamentary Under Secretary of State is the most junior rank. Each of the three, in practice, tends to concentrate, particularly the junior ministers, and the junior ministers are the Minister of State and the Parley Sec. They tend to concentrate on particular aspects of what is the most enormous activity, the National Health Service and social care and local authority social care. You all have to concentrate on doing particular bits. Minister of State, I was the nearest to having an all-embracing thing because health service is permanently controversial. And there's always crises over, I spent my time in hospital closures in those days, pay claims, all this kind of thing. But even then, you and the Parliament's divided up and have your own bit.
And then the Parliamentary Under-Secretaries of State for Health during this period, there was one in the Commons, who was Geoffrey Finsberg and then John Patton, and then one in the House of Lords, and that appears to have changed, I think, 4 times over the period you were Minister. Lord Elton, Lord Trefgain, Lord Glenarthur.
Lord Trefgarne, he's
Lord
called.
Trefgarne, my apologies. Lord Glenarthur and Baroness Trumpington.
Well, there were more, and Gloria Hooper was there, Baroness Hooper, because she took Baroness Hooper, what I remember best, because she took the very controversial health reforms, the legislation for my health reforms, which was my main activity when I was Secretary of State, through the House of Lords. So don't leave out Gloria Hooper. But I don't think Gloria Hooper had anything to do with blood products.
I'm just concentrating for the moment on those who occupied the positions in 82 to 85. We'll come on tomorrow to look at
Oh, I'm
those,
sorry. Yes, I've got the wrong dates. My apologies.
Now, you explained in your statement that the areas of responsibility for which you had primary ministerial responsibility did not include matters of blood policy, blood and blood products. And we've heard from Lord Glenarthur that was one of the areas allocated to him. What were your areas of responsibility as Minister of State for Health?
They were, overall, the political role vis-à-vis the National Health Service as a whole. Now, the 1980s, the National Health Service is the biggest business-like activity in Western Europe, the biggest employer in Western Europe. It is the centre, always, or has been ever since it was founded, of political controversy, usually crisis. In the 1980s, the industrial relations played a huge part if you were a minister dealing with any public service or any nationalised industry. So pay claims, strikes, the threat of strikes, actually, to an astonishing degree, dominated not only, the purporting of politics, but far too much time. And of course, we were having an extremely controversial battle as a government to try to sort that out in the Thatcher government. The other things that caused fantastic controversy, in which were mine, were hospital closures, building of new hospitals. The building of new hospitals were always opposed because of planning and because the bus routes weren't right. The closure of any hospital, even a disgraceful Victorian ruin, was a matter of wild controversy. The service was run, attempted to be run, by a centralised bureaucracy in the health service with thousands of officials who couldn't actually get themselves involved in everything from Wakefield to Truro as controversy came up. We did have health authorities, and you had to try to work with them. 15 regional health authorities, whom I met the chair quite regularly. They were very helpful, actually. They were a good way of pulling it all together. I can't remember how many district health authorities. They varied enormously in quality. Some were very political. Some were quite hopeless. Some were extremely good and didn't trouble you at all. They always complained they were short of money. The health services complained it's short of money ever since 1948, although the budget of the National Health Service has never been cut in any year in real terms by any government since it was founded. It's always gone up, but no one would ever know that because large parts of it run out of money. I'm giving you some idea. Now, I was involved in most of that, and that included me in a lot of politics, because then I have to then present that to the House of Commons. I spent half my life on the media because we were often in the middle of controversy. Both my stints at Health, I reckon I did the Today programme on the radio about twice a week, and so on. Now, that was, I actually was more involved in all that, and I had policies I put into that. I made the controversies worse by, I had a policy of getting rid of the old Victorian asylums. and getting rid of the old geriatric hospitals, which was a name they'd given to some of the old workhouses, which were a scandalous disgrace in which people were kept in appalling conditions. But there was a tremendous fight about closing them down. They were centres of clinical excellence. I won't carry you any more details, but that was my daily life in the Department of Health. And blood products was something that hardly ever came across my desk. I mean, obviously, as the tragedy with the haemophiliacs began to develop, I was aware it was there. And as you know, I'd from time to time, usually at my own instigation, got on the edge of it. But
And we'll look at
I didn't call meetings on. I was never the minister directly responsible for blood products. I was never asked to take a decision on blood products. I never intervened to take a decision on blood products. And I did intervene or get involved in discussions a bit when I wanted to be reassured. I was a bit concerned also. Simon Glenarthur wanted to touch base with me. I was aware it was going on. But just to give an example, I was greeted when I arrived. When I arrived as Minister of State, within 4 days, the entire National Health Service went on strike. It's the only national strike the Health Service has ever had. I mean, only in militant areas did it have a big effect because the staff of the Health Service won't go on strike. So it was only in London and Liverpool that things were quite grave. It became the longest public sector strike since the war, I think. So we went on for several months until we eventually resolved it. And I was the principal firefighter and involved in that. You know, visiting hospitals, I got caught up in picket lines sometimes, and so that took quite that was just a theme that, as I was getting used to the office, ran across all my things. I give you all this long answer. I'll try to make them shorter in future. Blood products, I was never directly responsible, unless someone pointed out to me that something was going on so far as the blood transfusion service or blood products. I had nothing to do with it, and that was true for most of my time in the Department of Health. The campaigners attributed everything to me because I later became a well-known figure.
Well, we'll come back to some of those issues, Lord Clarke.
That I was not involved in it, not directly.
How as a matter of organisation or allocation, how was it decided that blood products would be the responsibility of, say, Lord Glenarthur, rather than...
I imagine someone had put a submission to some Secretary of State. I don't know. I didn't decide that anyway. That's before I arrived. So
would the allocation of responsibilities ultimately be a matter for the Secretary of State?
He'd be the one who could change it, and they probably might change it if the permanent secretary or somebody suggested to him. I don't know. You must, if you're calling Norman, ask Norman whether. But when I was Secretary of State, because I eventually, my second stint, I know we're not talking about it now, but so just deal with this point. The only thing that I didn't change any of the responsibilities. They were, you know, as ministers changed, they inherited what their predecessor had done, and I suspect that had gone on for a long time. The only responsibility I got concerned about was who was going to do the legislation in the House of Lords, because I knew I was going to have a major and controversial piece of legislation, and I wanted to have some feeling as to who was going to do that. Hence I mentioned Baroness Hooper, who actually did it.
Did you, as Minister of State, have general responsibility for or some degree of oversight of the decisions taken or not taken by the more junior ministers?
No, not normally.
Do you know which minister, if any, was responsible for the work of the licensing functions carried out by the Medicines Division of the department?
No, but ministerial responsibility doesn't amount to much. The one thing ministers do not, ministers don't interfere with the regulation of medicines and the licensing of medicines. And the ministers are not clinicians. None of them, in my day, none of us had any clinical qualifications at all. You're not expected to be an amateur doctor because you're a minister in the Department of Health. those authorities are completely free of ministerial interference. So, apart from pay and rations, if there's some argument about their budget for the year, no minister would have anything to do with the decisions of the Safety of Medicines Committee or the licensing and so on. Of course, we had a whole lot of medics. The chief medical officer and his deputy medical officer and the medical officers, they were the department's people. The chief medical officer really was the person in charge of all the medical things. And when issues were clinical or scientific, or they touched on the treatment of patients, they would be heavily involved. The chief medical officer would was able to draw, of course, on the advice of the medical profession as a whole and get in. They always set up ad hoc committees of specialists in particular things to advise them, and then they give advice to ministers to make clear that the ministers understand the clinical and scientific position. Ministers don't second guess the medical. If you had some minister who'd got some pet theories about health and started suggesting an alternative treatment, one would rapidly get him removed to another department because that's not the job of a minister, and the medical profession would get very, very worked up. They did get worked up about clinical independence. In the end, the doctor-patient relationship is such that in the end it is the doctor treating the patient who's entitled to make his or her decision about the treatment of that patient with the consent of the patient. The idea that a minister's got anything to do with that, complete nonsense.
Well, we'll come back to some of those issues. So
and the key people in the haemophilia thing were obviously the haemophilia specialists, who were a very specialist group of medicines themselves. The average general medic would have been very cautious to give a view about the treatment and care of haemophilia.
We'll come back to some of those issues, Lord Clarke. Again, just dealing with some matters of general responsibility. Did as Minister of State for Health in the Department of Health and Social Security, what was the geographical reach of the department? Did it cover just England and Wales? England. Your recollection is just England?
My recollection is England. I mean, we didn't have, full devolution hadn't taken place, but I think the health service was always pretty devolved.
Do you recall any particular interactions with or measures for liaising with the Welsh office, Northern Ireland office or Scottish office?
Well, the first time I mentioned it today, I remember again, you're asking me about events almost 40 years ago. So I may have forgotten some incident, if you prompted me about some contact I had with Scotland or Wales. I don't actually remember at any stage having any dealings whatever with the Welsh office, the Scottish office, or the Northern Ireland government.
Do you have any recollection of whether the general understanding was that Scotland, Wales, Northern Ireland, either cumulatively or individually, would follow England's line, or was your recollection?
I really don't know. I've never involved. I know any contact, and I don't know. The devolution wasn't such a big issue then. I just can't remember. I assume because we were all members of the same government. I mean, the Scottish office ministers and the Welsh office ministers and were colleagues of mine in the government. But I think I don't think we did wildly different things, but we were run separately.
If we just look at one passage in your witness statement, Lord Clarke, Shomik, it's WITN 0758001.
Do you know what page that is?
Yes, I'll find the page, Lord Clarke. It's page 9, paragraph 2.1.
Thank you.
Page 9, please, Shomik. 9. You don't have a page 9.
Page 9, yes, I found it. Paragraph 2.1. 2.1.
So if you could forgive me for a moment, Lord Clarke, we don't seem to have it electronically available. It doesn't matter. You've got it, and there's only one sentence I want to ask you about, so I'll read it out. You say in the third line, the inquiry will be aware that at the time, the DHSS was responsible in England for the administration of the National Health Service. In addition, it was responsible for the social services provided by local authorities to the vulnerable in society and for some aspects of public health. Can you recall what aspects of public health fell to the department, or what other bodies were involved with public health?
I can't remember. I mean, the Department of Health always had a role in advising people, putting out separate running campaigns occasionally. Sir Donald Atchison, who became the Chief Medical Officer for a high proportion of the time, he was particularly keen. He was, before his time now, it's much more popular now, on disease prevention, health education, as well as being a highly conscientious man on treatment. And so the department did run some campaigns, probably in those days, trying to get people to give up smoking, trying to get people to take more exercise, and so on. And so that's what I think is. This is a description taken from some formal description of the role. That's the sort of thing the Department of Health does. And then, of course, there's constant interaction between the medical profession and the pharmacists and the dentists and the GPs and everything else with the department, because they have to interact all the time because we were administering them, and that included public health messages. The CMO would somehow, I think, he wouldn't put it to ministers, nothing to do with ministers, but he would put out newsletters to doctors and so on, and take part in the discussion, but it wouldn't intervene in the treatment of patients, but it would take part. That is the kind of thing the Department of Health did. In neither of my stints at the department did I have very much to do with that at all, certainly not as Minister of State. Secretary of State I did. We had a health education authority by then, and I usually deal with them occasionally, usually when they were trying to persuade me to allow them to run some fresh campaign. But the campaign would be their idea, and they dedicated to try and get to help them.
If you turn to page 14 of your statement, Chairman, I don't know if we have that right. Paragraph 2.22. You've referred in paragraph 2.22 to the Griffiths report, which was a report commissioned to look, as I understand it, at the management of the National Health Service in 1983. And you say this in the third line: the idea in relation to the latter, that was the establishment of a management board, was to remove the DHSS from the more day-to-day running of the National Health Service. And then you go on to explain how the management board was established in April 1985. You refer also to the establishment of the Health Services Supervisory Board. Would it be right to understand, in very broad terms, that as at 1983 and before the reforms recommended by the Griffiths report were implemented, that the department did have quite an active role in the day-to-day running of the NHS?
Well, it tried to. What happened was, every time anything went wrong locally, the Department of Health was blamed, and it was politicised. So the department felt it had to get involved, and the Department of Health spent its time trying to sort them all out. You may know there's a famous phrase from Nye Bevan, because he was the first one who created a service where he was in the middle of constant controversy, as every Secretary of State for Health always regarded as in crisis by the general public. And he once made a remark, I can't remember the exact word, but he found he made himself responsible every time someone dropped a bedpan in Rhondda. I think he being Welsh, I think he collected a Welsh example. He personally was held responsible. It ran in this rather chaotic way. The other problem, which I won't burden you with, is that there's been an attempt to reform the management locally of the service by Keith Joseph in the early 70s. And we produced a form of management which was called collective management. There was no one in charge in any hospital. There were officers, all of whom were equal ranking. It had been an idea of McKinsey's, which Keith had taken up. it did not work. Roy Griffiths, in his report, came out again with what came at the time a well-known quote, that if Florence Nightingale came back today and went to the nearest hospital and asked who was in charge, nobody would be able to give her an answer. When you talk about the Griffiths reforms, Margaret had got Roy Griffiths to come in to do this. He came up with a very good analysis of the problem, and we had these new institutions, but they didn't really make a difference. The reforms were what I turned up to do when I went back as Secretary of State for Health, and they involved much more devolution of responsibility, so long as they're accountable upwards, much more competition and choice when spending the money where you spent it. I was determined to concentrate on the outcome for patients, value for money, getting the biggest bang in terms of patients cured and treated for the ever-increasing amounts of money we were putting in. I was to get away from this bureaucratic shambles of squabbling all the time, the dominance of industrial relations and the politicization of everything. But the day-to-day running, I did try to stop it being done by the officials in the Department of Health in London, because it was a shambolic bureaucracy. And the controversies about it in the 1980s had reached a new peak, which is why Margaret got Roy Griffiths in, why she eventually declared she was going to reform it, and why eventually I wound up producing the reforms, because it could not have gone on as it was. It can only be described as, I mean, the officials, some of them were very good, they did their best, but the whole setup, the structure, was a completely shambolic bureaucracy, which is why blood products, which was a comparatively calm area until it had this horrendous problem that took us all by surprise when a new disease and new infection started emerging, was a quiet little part of all this. It was very big because of the tragedy now, big this inquiry, but the reason, when I arrived in 1983, the idea that blood products was a very, big part of the department's activity is just simply not true. It was a very specialist, usually quiet, harmless subject, one of the few areas where we didn't have controversy, and there wasn't very much for the department to do because the blood transfusion service ran itself.
Just again in general terms, and looking at this first half of the 80s, can I just explore with you various ways in which the department might exert some degree of influence over decisions of regional health authorities, NHS bodies, clinicians in general? One of the ways in which the department could exert influence presumably would be through its funding decisions, the amount of money it made available.
Would be what, sorry?
Through funding, the amount of money it made available to regional health authorities.
Well, the allocation of the funding was it dominated our lives, because, see, it's still true, I mean, it's true today. The health debate, as far as the public are concerned, is always about money. The party which is in opposition, their policy on health is always, it's short of money and we'll spend more money. And the party of government, their policy is always, it's never had so much money as it's had before, we put more money in last year, we will carry on putting money in. Of course, money is just the background. It's far more complicated than that in every area. What we tried to do was to allocate the money to the health authorities according to the needs, the respective needs. And again, I was more anxious in terms of patient care and then trying to hold them to account for the outcomes. But the allocation of money was done, therefore you'd get some sort of formula to negotiate. Sometimes the department would negotiate, but we allocated money on what we thought was a fair distribution between the regions and through them to the districts. What happened was that the control of money in the whole service was pretty useless. They couldn't usually tell you how much anything costs they were spending money on. And as you approach the end of every financial year, because we'd started enforcing budgets and cash limits, which had been even more chaotic before Margaret's day, the ones that had got spare money and found they hadn't spent their allocation would run around the hospitals asking anybody want to buy any kit for next year, anybody got the thing they want to spend some money on, and they get rid of it. The ones that ran out of money at about Christmas and so on would go to the newspapers and say that the cuts were causing them terrible harm and they needed more money and so on, and they were the ones the minister usually had to deal with. Sometimes you did have to bail them out. But that is, that is the relationship, I think, is about as clear a description I give. And if it sounds a little strange and shambolic, as I said before, if you want to go over broader health policy, it was very shambolic in the 80s. Had it not been for HIV and hepatitis, the blood transfusion service would have been an oasis of non-controversial calm. Hence, it was one of the ministerial duties of one of the Parliamentary Under Secretary of State, usually in the Lords.
As well as providing funding, the department could also influence regional health authorities by, I think nominally in the name of the Secretary of State, issuing directions or instructions, could it not?
Yeah, I had regular meetings. I began to try and get some order in it, because I had to work out how I was going to, not just defend the government, defend myself, but actually influence this and in some way and make some sense of it. And I had regular meetings with the Regional Health Authority chairman, and they became quite crucial to my relationship. They gave me some order. I actually, in appointments, tried to get some people in. I tended to appoint local businessmen with some business experience, and not particularly political people. We didn't want local authority politicians or trades union people, chairmen of health authorities. What I wanted was someone who had the motivation of wanting to serve a great public service, also had some experience of the managerial decision-making in a giant and complex organization, or actually sometimes medium-sized firms. And I had regular meetings with them. I got on very friendly terms with them. They were my best way of influencing the system through them. I used to joke with them occasionally. Several of them in later years became personal friends. They were my cabinet. I could get some order and stop dealing with the District Health Authority in Wakefield through the columns of The Guardian, if the actual Yorkshire Regional Health Authority chairman also got his hands on it and tried to find out what the devil they were up to in Wakefield and why they got themselves into this mess. But
so you could influence...
my answer's a little, chaotic and all that. It was a chaotic world, the NHS in those days.
So you could influence potentially, and I'm talking in general terms here, I'm not talking currently specifically about matters relating to blood policy. You could influence regional health authorities through the process of meeting, collaboration, information sharing.
With the chairman.
But was it also open to the department, if it thought it appropriate to do so, to issue instructions or directions?
I don't think so. I don't remember ever issuing instructions or directions. Might have done some to recalcitrant district health authority.
It was also open, was it not, to the department, or possibly here through the chief medical officer, to issue guidance to clinicians, dear doctor letters, leaflets? And
I think the chief medical officer, my recollection is mainly Donald Atchison, who was much more active than his predecessor. But I think chief medical officers generally do issue guidance and so on, but he'd do that off his own bat. He wouldn't consult ministers about that. And the chief medical officer would be the medical scientific issues of the day and the advance, scientific advance, that would be entirely the chief medical officer. They'd make sure that there was no gap. There was a rule, a tradition, a convention in the Department of Health in those days, may still be. Every time the minister, including the Minister of State or the Secretary of State, had a meeting, by which what we call by a meeting is a whole lot of half a dozen maybe 7 or 8, perhaps 2 or 3 policy officials where you're talking through and deciding something and getting briefed and all the rest of it. Every meeting had to have a medical officer at it, so that the non-clinicians, the ministers and the lay civil servants, didn't start wandering off doing odd things because they didn't understand the medicine and the science. So there would be a medical officer every meeting I ever had as Minister of State, and the medical officer would work to the chief medical officer. They would do all this stuff about newsletters and making sure that doctors were up to date in what was happening, although doctors usually keep up to date through their own professional bodies and through the medical journals, which any responsible GP and surgeon does his best to keep up to date with the constantly changing pace of medical advance.
And then the department could also put information into the public domain, could it not? Whether through press releases or through the more formal process of speaking in Parliament and answering parliamentary questions?
Well, you could make statements, but they were usually statements on government policy. I mean, the ministers are politicians and members of the government. So the ministerial role is not medical, clinical. It's not giving the minister's job is not to go around giving health advice to the public at large. The minister is the person responsible for financing, decision-making, delivery of the health service, and its presentation in Parliament, accountability to Parliament, and handling the wider, in the case of health, constant public controversy. Every Secretary of State Health always finds that he or she is the most controversial member of the government of the day. It's inevitable. I always warn my successors, for heaven's sake, don't think you're going to become popular when you're Secretary of State for Health. No Secretary of State ever has. You're in the middle of the constant presentation of your political role, your executive role, as the government minister in overall charge of it. The CMO is in charge of all the medical scientific stuff.
You have described, in the inquiry heard described last week, a parallel hierarchy within the Department of Health of the medical officers reporting ultimately to the chief medical officer, and then the administrators reporting ultimately to the highest, the permanent secretary.
The permanent secretary.
Within the department. One of the medical officers from whom the inquiry heard last week, a Dr. Wolford, who subsequently became a deputy chief medical officer and later on, was critical of that division. She suggested to the inquiry it was outdated. I think she used the phrase in her statement, the expert on tap but not on top.
The what, sorry?
The expert on tap but not on top.
She thought the medical officer should have a bigger role.
Well, I think she was critical of there being this parallel hierarchy rather than there being, I think, more interwoven. Do you have any reflections on that?
I hadn't heard it. Well, I've not really addressed the issue before. I have a lot of time for Diana Wolford. I mean, I haven't met her since I left the department, I don't think. But I'm sure if you showed me a photograph, I'd recognise her. The name is very familiar. And she was one of the medics who obviously advised me. But I don't know what change she was proposing. And what you couldn't have was the bureaucracy of the lay civil service taking medical or scientific decisions, and the medical officers were, on the whole, we had a good lot. The first chief medical officer I had wasn't very good, but Donald Atterson was a splendid man, saint-like man, but a very hard-working man. And Diana Wolford, I seem to recall, was one of the ones I particularly trusted and liked with her advice. I mean, I didn't realise it was that strict, the division. I just, we all worked together. I hadn't realised there was any tensions between them. Don't think so. I'm slightly muttering away, but you're asking me a question of structure I'd never even thought about before. I didn't know she was critical of it.
You say in your statement that you didn't have, I think you and your colleagues, rather than you solely, didn't have the requisite clinical expertise to go behind the expert advice provided by the chief medical officer and his team. that reposes an awful lot of trust, does it not, in the reliability and comprehensiveness of the advice you're receiving?
Yeah, you did, which is why you had to have confidence in them. And I mean, don't get me wrong. All the advice I've ever received from anybody, whether a civil servant or thing, the duty of a minister is to challenge people. I mean, if the advice surprised you, if an intervention medical officer, you know, I certainly, my style would be really the case, good grief, surely not, and so on. And if the Diana Walford or Donald Atchison gave me opinion, I would often debate it with them, and they would explain to me if I got the wrong end of the stick, you know, why they were giving that advice. But once we got Donald Atchison in, I thought, in fact, as it happens, the medical officers were amongst the higher quality people in the place. And what you couldn't do was start sitting there. I don't personally sit there and argue with my GP, and treat him on medical. You know, I don't start challenging his medical opinion. You can't start. I have no clinical expertise whatever, so you are relying on them. You have to trust them, but it isn't just them, of course, because they have to relate with the medical profession as a whole. So it's relevant to this inquiry. If you have a totally new disease, when HIV/AIDS emerged, about which nobody knows everything, and which causes panic because it appears to be fatal, there's no cure, and so on. I mean, they're heavily reliant on all the contacts they've got with the colleges of medicine, the specialists on the ground, and they themselves draw in. And what the CMO always does is, when we've got anything like this, because it's always, we've got COVID, you set up all kinds of expert advisory committees from outside. The CMO sets up all kinds of expert advisory committees of the people who are experts in this particular field where the problem has now arisen, so that his and his team's advice to ministers on the science is informed by getting all the experts.
So in general terms, you would expect, and indeed to some extent rely on this happening, you'd expect the medical officers to be drawing on the widest available relevant expertise.
I'm sure they did, yes.
Particularly in relation to something that's uncertain and new. Absolutely.
And when the question arose of HIV in haemophiliacs, which is what we're actually dealing with here, I'm sure that I'd be amazed if Diana Walford would have told you that they would be in contact with the people who knew most about it, which is the haematology specialists and the people who, you know, did specialize in the day-to-day treatment of haemophilia, who had been, you know, they're the ones that had started using this amazing new treatment, factor VIII. Well, that was a decision by doctors who specialized in haemophilia. And then when we started getting worried about the factor VIII, I imagine that our medical officers spent a great deal of time dealing with them. And I don't know, you would know, I don't know, but Donald probably did set up a little committee, didn't he, of haemophilia experts.
We'll come on to the committees and expert groups that were set up. But broadly speaking, if you have something like a new virus, would you expect your medical officers to be going not just to haemophilia clinicians to consider how it might impact haemophilia treatment, but virologists, epidemiologists, public health experts, to draw on all different areas of expertise?
Well, only got to look is easier, less problems of memory. There are a lot of comparisons to be drawn with COVID. We've got a really major national pandemic at the moment, but it's all the same parallels, completely unknown new disease that nobody knew anything about. And so all of us, everybody in this room, is familiar with talking about committees like SAGE, which is in our newspapers every day. Well, that is an expert group, I think, that's been brought together, assembled, I'm sure the lead's been taken by the chief medical officer of the day in doing that, and a range of virologists and experts, people with some, and others, and there are some psychiatrists and behavioral scientists and all this sort of thing, a team of people, but drawn particularly because they're leading specialists in the relevant branches of medicine for finding out something about this new disease and how we should react to it. Now, exactly the same thing would have been done in the case of HIV/AIDS. And then, when we had a subplot of HIV/AIDS, because we had this particular problem with haemophilia, hematologists we brought in as well. I mean, I say this, I think it would be done, but I just assume it was done, but it would be the chief medical officer who I would expect to do that.
So you're describing what should have been done in any event?
Yeah, and I think was, wasn't it?
Well, not for me to answer.
Well, they should. I'm not the right person to ask. You presumably asked Diana Walford.
Indeed.
She told him what the setup was. I think, I discovered, from the papers, I didn't know it before, she was a haematology specialist herself, which was a bit of good fortune that we got somebody in our own team who had a part of her career being a specialist in haematology.
Now, you've referred to Donald Aitchison, who I think became CMO in around October of 1983. So for the first...
Sorry, who was this?
Sir Donald Aitchison, Dr. Donald Aitchison.
Yes.
Or Aitchison. For the first 18 months or so then of your tenure as Minister, the Chief Medical Officer was Sir Henry Yellowlees. Did you have many interactions or any system of meetings with him?
There was Henry Yellowlees. I talked about first. Not a lot. Henry Yellowlees didn't immerse himself in these medical issues very much. Henry Yellowlees somehow, perhaps we just didn't hit it off, but I don't want to say upset his family if I say unkind things about Henry Yellowlees, but he didn't actually give much clinical advice to me. He didn't immerse himself in things. It was much better to deal with members of his team. I can't remember, obviously 40 years ago, I can't remember individual meetings or events, but had something come up about haematology, I would have found myself dealing with Diana Walford, not with Henry Yellowlees. And it was a huge improvement when we got Donald Aitchison in. Donald Aitchison was a conscientious, really serious, committed figure who immersed himself in what I think were the responsibilities of the Chief Medical Officer, and who would give me advice I'd expect from a Chief Medical Officer, and it was advice which I could have confidence, I always thought.
Again, in general terms, I want to get an understanding of how information might reach you as Minister. So the guardian, as it were, of the Minister is the Minister's private office. And so information would be provided by administrators or medical officers to your private office and then to you.
Every part of the department would pour papers upwards into the ministerial team. Usually, obviously, whichever minister was responsible for whatever they were doing. The Secretary of State's office got a very high proportion of the lot, because I was Minister of State, I would only get the things I was doing, and vast amounts of paper were pouring. When you're talking about paper, bear in mind we've also got ministerial correspondence, which was building up in the 1980s. It's even more, I'm sure, now. Thank God, we didn't have emails. But you get hundreds of letters would come in every day from members of the public and various other things. You've got all the parliamentary questions, large numbers of written parliamentary questions and so on. So unbelievable quantities of paper will be pouring in to the private office of ministers, and when I was Minister of State, but an awful lot of health service paper would come in. I had a private office of young, keen, rising civil servants, about half a dozen of them. One of them, probably the full-time job was sorting all this paper out. And the key role that the private office had to play was deciding which of this should the minister see, which must he see because he ought to see it, what would he want to see, because it really is relevant to things he's would want to get engaged in, and so on, and watch. And they would try to they would cope with all this paper, and get down to producing those papers which were going to be put in front of the minister, either physically on his desk or in the red boxes in the evening for him to do when he got home, come back with in the morning with his scribble all over them and his response to it, and in order to make it manageable. And everything else will be dealt with, officially, and that is the main source of information. Now, otherwise, you have what we then do. I would respond with issues. You'd respond probably to the papers. I would ask for a meeting. Then the next civil service process would be the meeting, where a collection of officials would come in dealing with the thing the minister now wanted to talk about. You'd start with the paperwork would be the basis you were working on, but then you'd have a general discussion. I like general discussions. I like challenging views. And so competing views, we talk it through, and 9 times out of 10 we come to a rough consensus at the end. The minister would have to take the final decision, but I personally would change my mind sometimes. I'd have some bee in my bonnet and be quite rapidly put right by some official who'd realise I got the wrong end of the stick and so on. And then that way you come to a settled, informed decision. Minister take a decision, and if it involved initiating action, right. As I would minister state, I wouldn't do it like this, didn't use these words, but that was what the minister decided. That's what we decided was the conclusion of the meeting, and then the machine is meant to go out, put that decision into practice.
We'll explore during the course of your evidence various matters that did get to you as minister and others that did not. Was there any guidance or yardstick as to what kind of issue did have to go to the minister and what kind of issue could left to be resolved by civil service?
No, there was any formal guidance. We had enough, for heaven's sake, we don't want more bureaucratic rules. In the end, it's a matter of judgment and common sense. It's usually fairly obvious that the minister is going to be involved in this. When some newspapers have come in about a strike that broke out somewhere, you raise your eyebrows and say, blimey, the minister better see this soon at the end of his next meeting. He'll want to know this has happened. Other things. We better get involved in this a bit and find out what's going on, and the minister might want to find out what's going on and so on. It requires judgment and common sense.
In general, when a minister in a department like the Department of Health took up their new post, what was the system for attempting to bring the minister up to speed with issues that fell within their areas of responsibility?
You'll be presented with huge piles of briefing. So you better settle down for a couple of days of intense reading, and then there's start to be some meetings so they can start briefing you. It's to be your way of meeting the people you were going to work with, the senior officials who likely to be coming to you, having meetings, different things, and you'd be immersed for the first week or two. A big department like this, you briefings and paper and so on, try to get you up to speed. You had to be very cautious. It's a sort of in those days, no one ever gave any training. Every minister taught himself how to be a minister, or herself how to be a minister. You were just plunged in. The first job I was ever given, I didn't even know where the department was. I had to find my way there. And as someone who'd never been involved in this kind of thing before, found I was being immersed in this thing of firstly huge piles of paper that I got to read on the subject, and then all these things. And as I became a sort of old veteran, and I don't usually go around giving boring old veterans advice, but I used to make a joke saying, just be careful what you do in the first month or two, because you will find your responsibilities are so massive that it take a couple of months before you really take a key decision, because you may regret it. And certainly don't, if you think it's a department don't sail in with pet ideas, instantly start implementing them, try them out, test them, use the opportunity to get in-depth knowledge of the subject, because politics is always conducted in terms of simple solutions, polarized opinions. Most government decisions are complicated, multifaceted, and you need to immerse yourself. In fact, I used to say that until you've been there a couple of years, you won't really understand it. Then you'll be an expert. You'll have real ideas of what you wish to do. Then you'll find the Prime Minister reshuffles you, and you have to start all over again. Fortunately, one of the reasons I look back with pleasure on my time at Health was the 2 stints meant that I was there for so long. By the time I left as Secretary of State, I was confident I knew exactly what I was doing, and it was my agenda. I was putting in place the things I thought were in the public interest. I thought were going to strengthen the health service, supported, fortified by all the briefing, discussions, arguments, everything else I'd had with my officials.
Was there any practice or system of regular ministerial meetings? Would you?
We used to have a weekly meeting, I think. I liked to in all the departments I was in when I was in charge of them, the later ones. You'd keep in touch, but you were also busy. Sometimes you'd see remarkably little of most of your colleagues.
Would those regular meetings be minuted?
I don't think they were usually. I don't know, but I mean, a private secretary would sit. A private secretary would sit in and practically every time you met anybody, but wouldn't always minute it. They were just a way of touching base, and it was, you know, they weren't formal. They were how are you getting on? You're having a bit of trouble, aren't you? You know, or Virginia with whatever it is, and you just kept in touch and then shared with your colleagues things which were causing you a particular problem. If you wanted to ask your colleagues, what do you think about all this? I'm having this particular row at the moment about this. What do you reckon I should do? They were that sort of meeting, just to make sure colleagues touch base with each other. I suppose the Minister of State and the Parliamentary Under Secretary of State for Health, they'd see each other quite a bit. There'd quite often be meetings where we'd hold joint meetings and we'd both be there in subjects which really cut across both our desks.
In terms of documents, we'll see as we go through some of the specific issues in which you became involved. There are documents, sometimes briefings, sometimes other documents that are no longer present, have not been found.
I'm sure there are.
I understand in relation to your private office papers, you had a particular way of marking the material that came to you.
I had a habit of underlining key phrases. Thick felt tin pens I used to use. That was so if I had to consult the document again, that I could skim read it and remind myself of what I thought were the really key telling sentences. And then this is the way I think a minister was expected to work. But as I taught myself how to be a minister, sort of. Because no introduction or management training of any kind was ever given to ministers in my day, when I started. So I would do this thing underlining, and I always scribbled on the top. Practically everything in the box would have my underlining, so they'd realise I'd reached it. Sometimes if I hadn't finished the box, they could tell which papers I'd not reached, and they put them in the next night's box, because there were no markings on the ones I hadn't reached, and they put the most important ones on the top. If I'd have a particularly busy day and was going to have only a few hours sleep, and sometimes you didn't always finish the box. I did do my boxes properly. And then I'd scribble at the top. Sometimes I'd just put content, you know. Sometimes I'd put a short sentence. Sometimes I put, we must have a meeting, get them in, you know, or whatever it is. And that kind of comment, which would be seen by the relevant member of my private office and would be their clue as to the next stop, or if it was just a comment, they might pass it back to the relevant thing, saying the Minister of State's read this and his only comment is. And obviously they called a meeting if I was asking for a meeting, or if I gave some strong opinion, they'd report the opinion and say, if you want to change it, perhaps you ought to come and see him if you don't agree with him, that kind of thing. But it was the private officer's job to filter the paper so it was manageable by one person, who had a very busy day every day in the office, and quite a busy day at the weekend usually. And then that was the way it went backwards and forwards. And particularly with me, they got used to dealing with me because they all got used to my habit of underlining everything when I read it, or the key phrases.
And is this right?
They knew they could expect my reactions on the top.
And for the most part, those original documents with your own markings on have not been.
So I discover, because you produce thousands of documents, 90% of which I've never seen in my life, the tribunal has. There's a huge archive somewhere in the country, God knows where, but the Department of Health does not appear to archive the documents, the originals, that, as they went to the minister or as came back from the minister. Obviously I got the same documents, but they're all pristine photocopies or something of the documents we then had. And there's a tiny number. I found about 2 or 3 which they're still photocopies, but they're photocopies of ones that have got my underlining and writing on. But a red box in those days, when I got a red box back in the morning, my office would have expected every document in the thing to have some underlining, a bit of scribble on from me.
And you,
I mean, apart from the letters, all the letters I have to sign, and everything else would be in the red boxes.
and as I understand it, so that there's no mystery about it, you don't know what the system was for retaining those or why they're no longer available.
I had absolutely no involvement in keeping the archive. I don't think it was a high-profile, high-priority part of the Department of Health's responsibilities. Some poor soul drew the short straw of having to organise the archive.
In the course of your ministerial duties for the period 1982 to 1985, as far as you can recall, did you ever visit a regional transfusion centre?
I don't recall visiting one. I used to do lots. I did lots of visits, but no, I don't think I ever did visit a regional transfusion centre. My only first-hand experience of the blood transfusion service was I was a blood donor. I think I was a blood donor in those days.
Did you ever visit a haemophilia centre, as far as you can recall?
A haemophilia centre?
Yes.
No, never. I don't think.
Did you meet with clinicians? Generally, did you have meetings with clinicians from time to time?
Very occasionally. I would meet them, but because they'd always get me along to dinners. So medical dinners I would go to, but they were. That's how I'd meet a lot of doctors, because, not surprisingly, if you get invited along to a dinner of the Royal College or whatever it is, most of the evening would be spent with various doctors lobbying you, or you're asking questions of doctors. It was, apart from the social side of it, that was the main contact I had with practitioners. For groups of practitioners to come in, I don't know. Unfortunately, I don't think anybody's kept my ministerial diaries. They've not made their way to the archive. But I don't recall very often meeting. When I visited the hospital, of course, you spend your entire time in the company of the doctors who worked in that hospital, who would spend their time showing you what they're doing, going around explaining things, and lobbying you sometimes. Or
what about patient groups? Did you meet with representative patient groups?
We didn't have many patients groups. No, I didn't meet with many patients groups, although, despite what I was saying about that, I thought getting the service to concentrate on outcomes to patients as its main objective, and not relationship with its principal trades unions as its main concern, was one of my major activities during the time I was there.
And did you ever meet with people who had haemophilia, who suffered from bleeding disorders?
I don't recall ever meeting. In fact, I've rarely in my life met anybody with haemophilia, I think I have to admit.
I just pick up on a phrase you used earlier in relation to doctors. You talked, I think, about clinical independence, and I think either your statement or certainly the statements of others have referred to the concept in terms of clinical freedom. What did you understand by that at the time?
Certainly the government and politicians should not start interfering with the way that they treated their patients, that they were their principal responsibility. The very great role of a doctor is to be quite independently responsible for giving what he or she thinks is the best treatment to the patient they're trying to help. And they should not be inhibited by anybody. They shouldn't, by lobbyists or anybody else, in using their best clinical judgment in the interests of the patient they're treating. And so the medicines they prescribe, the treatment they give, all that is entirely the discretion of the doctor. I had disputes with them in a quite separate area because I think the prescribing of medicines began to be abused with the prescribing of totally non-medical things by doctors lobbied by their patients. And I tried to, and prescribing very expensive versions of drugs which the health service could obtain much more reasonably priced generic alternatives to. That was the only issue I had, where those who disagreed with me started hurling allegations at me of interfering with their clinical freedom.
I understand why the department would not interfere with an individual clinician's dealings with an individual patient. But more broadly, would you accept that doctors were employed by the National Health Service for whom the ministers within the Department of Health were politically responsible, politically accountable?
Well, they were employed by some of them were employed by the health service. I mean, GPs have always been, they're private sector. They're independent, self-employed people, or they're in partnerships, and they're in contract with the thing. We've always been a large private sector part in the health service, like the community pharmacists. They're not employed by the health service. The hospital staff are all employed by the health service, which means their employer is the National Health Service, which is the responsibility of the ministers. But that would have been an outrage if some minister had thought that meant you suddenly told doctors that you give this treatment and you don't give that treatment for a particular condition.
Would you accept that the department and the ministers within the department had a responsibility to ensure that the treatment being provided through the National Health Service to patients was safe?
Yes, that's why we have this network of safety of medicines committees, licensing authorities. They have legal power. It's illegal for the doctors. That's the real control, to make sure you don't have some eccentric doctor who is prescribing things which are not actually clinically proven or sort of, recommended. But never does the minister personally start intervening and imposing a personal decision on what treatment a patient should involve. I mean, the great borderlines to all this, just to give you an example of a problem which we won't get any further unless you particularly want to, but homeopathy, which is an alternative medicine regarded by the vast majority of the medical profession as crank nonsense. For historic reasons, homeopathy was provided by part of the health service. We even had a homeopathic hospital for reasons I won't go into. It was dated back to the 1940s. I mean, so that was a fringe thing, because the overwhelming majority of medics, I mean, I'm not entering into this dispute, but the vast majority of medics would say that the treatment was useless. And indeed, I've known medics get quite excited about homeopathy, but there are specialists in homeopathic medicines who insist that they're entitled to provide it. And I say we had I think it's much diminished now. I think it's vanishing, but I'm out of date. They had fringes like that, but if that was ever resolved, it would in the end be resolved by medical opinion. You couldn't just have a minister could only intervene if the medics had told him that they're killing people and you've got to stop them.
If the department, whether through the chief medical officer or otherwise, were to publish and make available to health authorities, hospitals, clinicians, information about an emerging new virus, what was known to be the risks, what might be the pros and cons of particular measures that could minimise that risk, that wouldn't be an interference with clinical freedom.
Well, the CMO did that, didn't he?
Not in 1982, 83 or 84, no.
Did he not? I thought the CMO occasionally put out newsletters and things.
The first newsletter that we'll look at, I think, in relation to AIDS from the CMO is in 1985.
Yeah, well, that was the decision of the CMO. The CMO couldn't, it wouldn't do it much. I mean, the main source, the doctors on the ground, we're obviously frightfully worried. I mean, I'm not sure, whatever stage you're talking about, time it by concern grew. So the people mainly involved here, and most of the issues in all this are actually issues for specialists in haemophilia in the health service and specialists in AIDS in the health service. They would all be very concerned. Now, their main source of information, apart from each other and their conferences, would be the medical journals, where all the latest research, information, and so on is published. So if you're a worried doctor wanting to know more about where on earth is this disease coming from, are there some terrible downsides to this treatment, you would go to the Lancet. And the Lancet's only one of large numbers of journals where streams of research papers come out, and any doctor wanting the most up-to-date knowledge relies on that and his colleagues, not the Department of Health, certainly not politicians in the Department of Health, to which if any politician started giving an opinion, any sane doctor would say, what the devil has it got to do with him? And the medical profession is a self-governing profession. It's a very outstanding profession. And the process of constantly changing clinical progress and medical advance, which makes the health service now vastly better than it was in the 1980s. It's huge, we're living in a far better world now than in the 1980s because of all the fantastic clinical advance. It's the professional organizations, it's the journals, it's the dissemination of scientific research. That's where you get your information from. People don't look, the doctors in the field don't look to the Department of Health to tell them what to do when it comes to treatment.
There are specialist clinicians who have told this inquiry that it would have been enormously helpful for them to have advice from the Departmental Chief Medical Officer in this critical time in the early part.
On what subject?
In relation to AIDS and how to deal with the risk of...
Well, if the Chief Medical Officers had got, what did Diana Walford say?
Well, there's nothing... My question to you, Lord Clarke, is this. There was nothing to stop the department, whether through the Chief Medical Officer or otherwise, from providing information and guidance and advice.
No, I thought they did occasionally, but they had to be cautious, and they couldn't issue instructions.
So I note the time, and I'm going to move on to a slightly different topic, so it might be a good time for the first break.
Yes, I just would like to say two things before we do break. The first is that, as people here will be aware, the media have a particular interest, no doubt because of the prominence of Lord Clarke, in the evidence that we're hearing this week. And I thought it was the right time just to remind the press, who've been very, very good, I have to say, up till now, that they should not, please, take any photographs either in or outside the building in the immediate vicinity without checking that the person that they're photographing wishes and is happy to be photographed, and taking care that others in the background aren't simply identified or identifiable by mistake. I've said this on a number of occasions, or words to this effect, and it's now, I think, an appropriate time just to remind those out there on whose cooperation we do depend and which we do value. Lord Clarke, what I say to all witnesses who are giving evidence at this stage in their evidence is there'll be a break. In that break, it'll be about half an hour on this occasion, there'll be longer breaks later on, and of course you'll be here for 3 days. At any break, you must not talk to anyone about the evidence you have given or the evidence which you expect you may be asked to give. You can talk about anything else you like. You'll know this sort of warning from your days at the bar.
Precisely. I am familiar with that. No, I'm not going. I assure you, until I've finished giving you my evidence, I'm not going to discuss my evidence with anybody.
Thank you very much. Well, we'll take a break now and come back at 10 to 12.
Can I safely leave these papers here?
You can, yes.
They're safe.